We have recently performed a retrospective multi-center study trying to understand if using Polatuzumab vedotin in combination with Rituximab with or without Bendamustine may be safe and effective for patients with relapsed or refractory large B-cell lymphoma who relapse after standard of care anti-CD19 autologous CAR T-cell therapy. As you know, CAR T currently are able to cure about 40% of patients. That means that about 60% of patients with large B-cell lymphoma, unfortunately, will eventually relapse after CAR T-cell treatment. And there are really in the US 4 options available approved by the FDA to treat these patients. This includes selinexor, which is an oral XPO1 inhibitor, 2 anti-CD19 targeting agents, tafasitamab, usually in combination with lenalidomide and Lonca-T, and then finally Polatuzumab vedotin, which is an anti-CD79B antibody. The limitation of using anti-CD19 targeting agents is that unfortunately 30% of patients who relapse after CAR T do not express CD19 anymore. Hence the interest to look into agents targeting instead CD79B such as Polatuzumab. In this study, we were able to identify overall 54 patients with relapsed or refractory large B-cell lymphoma who relapsed after standard of care CAR T and received Polatuzumab with Rituximab with or without Bendamustine. What we saw was, first of all, use of this combination was safe. This is very important because typically Polatuzumab associates with neuropathy if given for a prolonged amount of time, but it can also associate with myelosuppression. And we know that about 30% of patients who receive CAR T 30 days after CAR T-cell infusion may have very severe cytopenia, including severe neutropenia, thrombocytopenia, or anemia. So myelosuppression doesn't seem to be a limiting factor for the use of Polatuzumab in these patients, and pretty much no patients had to interrupt treatment because of toxicity. Efficacy data, however, were partially disappointing. Response rate was only 40%, with 10% of patients being in complete response. And when we looked into factors that were associated with worse outcome, they were mainly bone marrow involvement or very high LDH. So patients who have had a very high tumor burden at time of relapse after CAR T cells did not respond well to Polatuzumab. The other disappointing efficacy observation was that duration of response tended to be really short, usually in the orders of weeks. The main take from this study is that Polatuzumab can be safely used for patients who relapse after CAR T. However, response is limited to patients who have low tumor burden, and duration of response can be really short. What this entails is that we should look into this option, but keep in mind that for patients who achieve a response after Polatuzumab, we should look into consolidation strategies, and these may actually include autologous stem cell transplant. This is very relevant because many patients today may receive CAR T-cell treatments without receiving previously autologous stem cell transplant. And this may become even more common now that in the US, Yescarta has been approved by the FDA as a second line. So we will have more and more patients relapsing after CAR T-cell treatments, again, particularly now that CAR T is available in second line. And Polatuzumab may be a very nice third line option, but again, based on our retrospective multi-center data, may only represent a bridge to a more consolidative strategy such as autologous stem cell transplant.